very fixable thing, and that's why Gavi's so important. There's a wonderful little vignette in the morbidity MMWR, the CDC's weekly report in 1996, about the first human case of the first human treated with penicillin in the United States in 1942 or 43, and penicillin was so rare in those days and was used in Britain in the war as well that they recrystallized it from urine so they could reuse it on the next patient. But it's real Jesus in a bottle stuff. So that's the kind of the stories of HIV now, with 33 million people infected, maybe 2.7 million newly infected each year, counterbalanced by about 2.8, 2.9 million deaths, and with huge epidemics in southern Africa, with in excess of 30% of adults infected in countries like Swaziland and Botswana. Botswana is a very affluent country, same gross domestic product as Slovenia. Slovenia. A real mess in Namibia in the north as well. And it's not getting any better. It hadn't been getting any better, but now, really with the rollout of antiretrovirals, and not a lot happening from a prevention standpoint, they're starting to really see changes in survival that we've actually gone way out on a limb on and calling in Botswana. And you're really starting to see true therapeutic effects, and it really is a Lazarus story. My story is a woman in a town called Tororo, which is in rural Uganda. As you drive out of this is my daughter's essay for Stanford. She drive out of Kampala and cross the White Nile at Jinja, which is a sort of a harrowing, crummy little bridge. It's on the other side of Jinja, up about 2 hours to the northeast by Mount Elgin. There's this town called Tororo, and Tororo is where all the cement comes from in Uganda, because there are a bunch of rocks there. What a surprise. The U.S. Centers for Disease Control set up a big demonstration project there where they were delivering medicine to home and tried to really do a full-on press and see if you could really, get serious therapeutic benefit. And a woman who was probably 40 years old, several children dead of AIDS, HIV, husband dead of HIV. She weighed about 80 pounds, started antiretrovirals. Now, within 6 months, 120 pounds, working in the garden. Everybody has a garden behind their house, which was where they grow stuff. Working in the garden, it was just truly amazing. And in fact, in this large cohort of about 1,000 people, of whom 800 were women, this is largely a disease of women in Africa, there was something like 80 new pregnancies in the first year, because people had gotten well enough to ovulate again. And, so it's all, so that's a sort of a problem. They shouldn't be getting pregnant, probably, or at least it shouldn't be unplanned pregnancies. But it gives you an idea of how physiologically they can recover so quickly. Now, that's all good news. The bad news is when all this stuff starts to wear off. We have there's a big supply chain problem, as you can imagine, and people can't go on and off drugs, because if you go on and off drugs, you breed resistance, and then you start transmitting resistant drugs, and it becomes a real mess real quickly, which is in fact what's happened with tuberculosis in parts of Africa and parts of the world as well. So I just wanted to add one other thing, and just lest you think that all the stories about HIV are in Africa or in San Francisco. We actually do a ton of work in Iran, of all places, where they have a very large HIV epidemic that's concentrated in drug users. Iran's a traditional opium-using society, like China was before the British fixed that problem with the 2 opium wars, and got Hong Kong in the deal. And it was, but Iran, surprisingly, so it's like 25% of drug users are infected in Iran. Huge problem, 100,000 cases, the most in the Middle East by far. Iran has a surprisingly liberal policies around HIV and drugs. It's sort of to the left of the Netherlands. They have needle exchange, which is something we don't have in this country, at least officially. They have treatment on demand. They have opiate substitution therapy, like with methadone and buprenorphine. They have needle exchange in prisons. So it's this kind of wild story that's an interesting one to tell. So I think that's enough cognitive dissonance.
So we have a few minutes. So if you have a question, raise your hand and we'll have you, okay, stand up and either you can go, there's a mic here or here, well, here, right over here. So please.
Can I just speak loud?
Or speak loudly, that's
No,
fine.
Go to the
Is
microphone.
it- oh, I guess because they're recording it.
Yeah, we're recording.
Yeah.
Hi, first of all, thank you for the great presentation. I've got a question. You read stories about food aid going out to third world countries and the food falling victim to the corruption of the regimes at the various third world countries where the food is taken and sold on the black market and never gets to the people that you're trying to get to. And this is, I guess, a question for the people that deal on the international level. Is there a political component to this from the standpoint as you're trying to deliver these services or this aid where you run into the political resistance of the local politics? And does that make it more difficult? Because it seems like there's the potential for a political intrigue storyline on this.
So Dr. Yamada, I guess to translate your question in terms of medicine, say, is there this problem that you're facing?
Well, first of all, every country has a different story. It's not all countries being the same. But if you look at the two largest drug programs in the world, antiretrovirals for HIV and the so-called DOTS program for TB, directly observed treatment, short course, by and large, the medicines get to the people who are supposed to get to them. And I think they're very largely successful programs. They were built the right way. The UN's been involved. If you look at vaccine programs have also been very successful. What's interesting is that Africa now has almost a 75% vaccination rate for the standard vaccines. That's a huge increase from what it was a few years ago. So yes, there may well be corruption in some of the areas, but in the areas that really count, as in HIV, TB, and childhood vaccinations, the story is better than you might expect. I can't really comment on food, and because I really don't know what happens with food. But this isn't to say that I'm a Pollyanna. I know there's corruption. There are lots of whole-scale issues. If you just take Nigeria, the state gives money. I mean, the government gives money to the states. The state money never gets to the communities. No one knows where it goes. So it goes somewhere, but it doesn't go to the patients. So I think there's corruption, but for the things that are big programs now for medicines and vaccines, they seem to be working.
Can you, you just spoke about medications. How good is compliance? Because there's lots of, I think, stereotyping about compliance outside the U.S. What do you see in terms of compliance and
Well, the
for
best
antiretrovirals?
studied one, Dr. Rutherford probably knows better than anybody, is that they took Uganda as an example and followed what happened to HIV patients in Uganda, and compliance turned out to be in the 75% range or so, which is better than comparable programs have been in the U.S. So given the medicines, the patients in the developing world take it as compliantly as patients would in the United States.
I'd say it's actually more so,
More so
higher compliance.
outside the U.S.
I guess I have a slightly different perspective. Malaria is a somewhat different disease than AIDS and TB. AIDS and TB, the drugs are largely delivered through international donors down to government-run facilities, and they are fairly well maintained. The vast majority of malaria is treated in the private sector. And within a week of Cambodia releasing the latest new drug, this was a few years ago, there was an identical counterfeit that was in the market, absolutely no drug in it, that looked identical, even had the same hologram on the package as the packaging. One story from Africa, I was in a meeting. We were trying very hard to get a country in Africa, I won't say who it is, to switch their policy from chloroquine, the old drug, to newer drugs. And the Deputy Minister of Health got up in an international meeting and explained why he didn't want to switch by saying, even though you have a wife, even though you have a mistress, you keep your wife because you know her. And the bottom line was, and his argument was, we know chloroquine, we're used to it, we're nervous about this new drug. The reality was his brother-in-law owned the company that manufactured chloroquine. And we do see leakage of antimalarials and bed nets into the private sector from the public sector. We are taking measures to deal with that, but to some extent, personally, it means someone's getting those drugs and someone's getting those bed nets, so I don't lose sleep over it.
Thank you. Next question.
For Dr. Yamada and the rest of the
Can you come to the mic? Thanks.
For the panel and Dr. Yamada, concerning public health authority globally, especially concerning things like, I just heard about the sex workers in the porn industry. Here in LA, 2 new HIV cases, then the local public health department, and I think Cal OSHA couldn't get the names, and then swine flu coming across the border. Should we have quarantine? What's our global public health authority? And by the way, I'm a former chief resident in pediatrics, so hello, Dr. Radford.
Well, I do worry about the public health system in the U.S. There was a day back in the 40s and 50s when mass campaigns were going on for polio, for example, and the threat of a public health hazard was very real in the minds of generally citizens all over the United States. But I think we've been lulled into a sense of complacency, and given what's happening now with pandemic flu, interestingly enough, even if we have the vaccines in the U.S., the sheer logistical challenge of vaccinating a couple 100 million Americans, not once but maybe twice, is something that the public health system hasn't really thought through. I recently talked to Tom Frieden, who's the new head of the CDC, and he views this as a very substantial challenge because the people that need to be vaccinated for H1N1 flu are the people, largely the people in this room. It's not the very young and the very old that are dying. It's actually people in the middle that are dying, and those are the people that are hardest to reach with vaccinations. But I think that, interestingly enough, if you look at the developing world, they're used to giving mass campaigns. You know, countries give mass polio campaigns or measles campaigns or, hepatitis B campaigns and so on. And so the infrastructure is there in many of these countries to do large-scale public health interventions, especially in vaccinations, that we don't have in the U.S. So it's a paradoxical situation where we're less prepared for a huge public health hazard than maybe some of these other countries are.
Yes.
So we've talked a lot tonight about the medical approach to solving a lot of these issues, but what about the preventative educational approach? I think that seems to be left out a lot, and it's a pretty widely known topic in public health, but public health has sort of been ignored in the past few years, as you were talking about. But I was wondering, I started a health center in a refugee camp in Zambia, and I think that this proves the educational aspect that I'm trying to figure out why it's missing in our discussions nowadays. It brought a simple thing like malaria bed nets, and people got them from the UNHCR, and no one was taught how to use them, so no one used them. And there was about 18,000 people who had been diagnosed with malaria in the medical center there. After we came, we taught the people very precisely how to use bed nets, and the next year there were only 7,000 cases diagnosed. And that just shows that people do learn and take things very seriously, and it seems like a lot of times we throw medicine and we throw these easy solutions when instead you can educate people and it will empower them so much more. It's sort of the teach a man to fish or give a man a fish approach. And I think I'm so confused as to why education